My name is Gwen Hornbeek, and I will be presenting to you my Doctorate of Nursing Practice Quality Improvement Project entitled Improving Depression Screening in Adult Women in a Rural Primary Care Setting. Depression is considered one of the top 5 health concerns for women. In the United States, about 15 million people suffer from depression each year, making it a common but very serious disorder. Depression is a mental illness that is commonly underdiagnosed and undertreated because routine screenings are not a standardized practice of care in primary health care. Depression disproportionately affects women, with statistics showing women are twice as likely to experience depression than men. This adversely affects their overall health and well-being, causing an increase in the lifetime morbidity and mortality among this population. In fact, studies show that about 1 out of 10 women in the United States reported symptoms that suggest they experienced an episode of major depression in the last year. Primary care providers play an essential role in healthcare promotion and prevention. Even though these providers happen to be in a unique position to promote depression screening for women and improve overall outcomes for this vulnerable population, they are missing opportunities to ask women about depression. With many rural communities lacking proper facilities to treat depression, the primary health clinic serves as a first-line defense for identifying and treating patients who suffer from depression. Despite evidence-based recommendations by the United States Preventive Services Task Force, the Centers for Disease Control and Prevention, and the American College of Obstetrics and Gynecology to screen for depression in women when adequate systems are in place, national depression screening rates are still found to be less than 5% in primary care settings. Currently, there is a lack of depression screening in the project facility. The patient population at the project facility is currently 60 to 70% women. This is significant because statistics show that women are twice as likely to suffer from depression than men, meaning that not screening is most likely missing an opportunity for early detection and treatment. Despite the increased prevalence for depression in women, the study facility did not screen, offer, or promote depression screening for women on a routine basis before the initiation of this quality improvement project. After review of literature, it was revealed that a depression screening protocol that included multiple evidence interventions is most likely to produce the most favorable outcomes of improving depression screenings and treatment among women. The purpose of this study was to evaluate the implementation of an evidence-based standardized depression screening program that included staff education, implementing a clinical reminder in the electronic medical records, screening protocols, and patient treatment plans that aim to improve depression screening rates among women in a rural primary care clinic, ultimately reducing adverse outcomes related to undiagnosed and untreated depression in women. The overall aim of this project is to improve depression screening for women across the lifespan in a rural primary healthcare clinic through education, integration of the screening tool, and the adoption of treatment algorithms. To achieve this, a goal of improving screening rates to 80% was set for an 8-week period. To achieve this goal, the first objective was set to ensure that 90% of clinic staff were trained on depression, screening guidelines, and the standard protocol by the end of a 2-week period, followed by increasing the clinic depression screening rate to 80% over an 8-week period, and lastly, offering treatment plans to at least 75% of the women who screened positive for depression over an 8-week period. This quality improvement project took place in a rural community primary care clinic, serving predominantly patients of lower socioeconomic status that receive Medicare or Medicaid as their primary source of insurance. The participants of this project were women ages 18 and older. Women eligible to participate in this project are those who were scheduled for annual wellness or new patient visits. Both English and non-English versions of the screening were made available for the inclusion of all women who met criteria. Women younger than age 18 and individuals scheduled for any other type of visit were not included in this study. All individuals that met the inclusion criteria were asked to participate in the screening process, and participation was voluntary with verbal consent. The tools used to implement screening were the Patient Health Questionnaire 2 and 9. Both tools are able to be self-administered and take less than 5 minutes for patients to complete. Those screening positive on the PHQ-2 were further screened using the more in-depth PHQ-9. Project interventions included staff and provider in-service, development of electronic medical health record system alerts, and provider task prompts embedded in the client clinical note. Data was collected after completion of patient education, screening, and depression screening scores. All of this data was collected and documented in the electronic medical record. Data was collected using paper-based screening tools collected from patients during their visit, and scores were recorded on a password-protected Excel spreadsheet using the SPSS data tracking software. SPSS statistics software was used to develop statistic and secondary analysis of the data collected. Results show that the implementation of a standardized depression screening protocol increased overall depression screening rates from less than 5% to 84% during the 8-week study period. Further analysis found that 85% of patients screening positive for mild to severe depression have been offered a treatment and follow-up plan. The following flowchart depicts a depression screening protocol and treatment algorithm with results obtained during the study period. During the study period, 71 patients agreed to participate in the study. All 71 completed the PHQ-2 depression screening. Of those, 55% were determined to have positive symptoms of depression and warranted further screening using the PHQ-9. Scores were interpreted based on the PHQ-9 translations. 45% of the sample population scored between 0 to 4, resulting in no necessary treatment actions needed. 34% scored between 5 to 9, signaling mild depression with the treatment plan indicating watchful waiting and repeat screening at the follow-up visit. 20% scored between 10 to 27, signaling moderate to severe depression and warranted further treatment with combination therapy of pharmacologic and psychotherapy, with a referral to the behavioral health provider. In conclusion, women living in rural areas most often use primary care as their main source of health care, including their mental health needs. Research has shown that implementing evidence-based guidelines to screen for depression in primary care is beneficial. The use of an evidence-based intervention within a standardized depression screening program not only significantly increased depression screening and education, but also considerably improved the overall depression screening coverage for women in a rural primary care clinic. In this project, the development and implementation of a charting tool in the electronic medical record along with education were associated with improved provider depression screening rates and compliance documentation. All objectives were met during the implementation phase except for offering referrals to women that screened positive for mild to moderate depression. This rate was significantly lower than projected due to missed opportunities, the COVID-19 pandemic phase guidelines, and declination rates. This quality improvement project contributes to findings for recommended best practices, which includes education, universal screenings with a standardized depression screening tool, referral for appropriate evaluation, and treatment by mental health providers when indicated. This quality improvement project shows that evidence-based interventions can be used to improve depression screening rates among women in a primary care clinic, which ultimately reduces adverse outcomes associated with depression. Implementation of a standardized instrument such as the PHQ screening tool in the clinical setting was shown to be beneficial. as an intervention in promoting early detection and treatment of depression symptoms, which can enhance overall health and well-being among women. This can also help to increase routine screening compliance in the primary healthcare setting. The sustainability of the depression screening protocol is essential to reducing barriers and improving quality of care in this vulnerable population. During this quality improvement project, several future recommendations were identified. It is recommended that depression screening continues in the future to ensure early detection and treatment across all ages and populations in the primary care setting. It is also recommended that providers continue to follow up with patients who screen positive for mild depression. Also, the development of a standard approach for follow-up to ensure treatment effectiveness. And lastly, the development of a multidisciplinary approach for treatment with the local mental health facility in an effort to minimize the gaps between the diagnosis, referral, and treatment. This will allow for patients to receive some type of treatment while they're waiting for their evaluation from a mental health care provider. This concludes the presentation from my quality improvement project. Thank you for your time and interest in my quality improvement topic.